So today I'll talk about the classification system of mechanical diagnosis and therapy, MDT, and kind of how I frame it in my head, which may help a patient, but I think this thought process may help other clinicians, especially those who are novice at learning and using repeated movement testing in their orthopedic evaluations. So in MDT, we use the word classify, which out of the gate, I don't like to use that word. I never use it with patients. The reason being, they don't use that term. Patients don't use that term. Other clinicians don't use that term. And I'm very comfortable using the word diagnosis. I'm curious if maybe the impetus for using classification was because it's more of a physiological disorder versus an anatomical disorder. But to me, using the word classify versus diagnose is softer, if you will, and lends less credibility and confidence to what the clinician is saying. So I'm using the word diagnosis and the verb to diagnose because I'm very comfortable saying that we can diagnose physiological disorders. And just because another clinician doesn't diagnose this way or use these tests or these terms doesn't mean that it's wrong that I do, because I believe in mechanical disorders, what Robin McKenzie called mechanical joint derangements. So the classification system, I just don't even like kind of that term. Use diagnosis if you want to. That's what I use. So we can diagnose in MDT, the main buckets are joint derangements, so mechanical disorders, articular or contractile dysfunction, so dysfunction is the key word there, postural syndrome, and then of course other. Now, other is a somewhat large bucket of everything else. And within MDT, whether it's within the McKenzie Institute in the United States or in another specific country or the international governing body, that the nomenclature, the system is evolving and the nuances may change a bit. But the classification system still remains in terms of kind of those buckets, if you will. I prefer to separate it a little bit differently, to think of it in different terms. I think of mechanical joint disorders, joint derangements. I have no problem with the word joint derangement, although I just don't tend to use derangement with other people as much as I just use disorder. Yes, disorder is a more general term, but I think people can get on board a little bit more with mechanical joint disorder versus mechanical joint derangement. But I'm very comfortable with either word. It's just about trying to bridge that gap with other people. For the same reason, I want to use the word diagnose or diagnostic system versus classification system. Anyway, so I kind of think of mechanical joint disorders as the mechanical disorder. Now, I believe that dysfunctions and postural syndrome are also classified under the mechanical umbrella. And again, I've said this before, the word mechanical and mechanics tends to be defined differently, somewhat by different people. So when you're speaking with someone and you want to be clear, you should kind of define your terms from the start. For me, I think of that as the mechanical disorder, a joint derangement. And now, for other clinicians, I think especially people who are coming to learn repeated movement testing and learn MDT after they've already done all of their schooling in particular, meaning they really have a guiding set of principles about orthopedic disorders. And this is throwing a huge wrench into that thought process. For those people, I kind of want you to think about, I want you to have a little bit more confidence, and you already know a lot of this. I would argue you don't know the most important part, not because it's your fault, but because you weren't taught it, just like I wasn't taught it. And as a personal story, I dealt with disc herniations that were very problematic, and I had no real solution until I learned repeated movement testing and learned what a lumbar side glide was, for example, and learned what prone extension with hips in a side glide is. So these types of clinicians especially coming out of school or who've been practicing for a while, so people who did not learn this in school as part of their academic study, where by learning it in school, it's given some credibility. So the people coming to it later are kind of coming to it with like, I wasn't even taught this in school. Is this worth its salt? Does it hold any merit? I want you to think of dysfunction. Well, I don't want you. I'm just offering this as a framework that I use. Separate dysfunction into the two parts that it has. Contractile dysfunction, just think tendinopathy. Contractile tissue is dysfunctional, tendinopathy. A muscle tear or a muscle strain, if it's the symptom generator, is going to be an acute lesion. So to me, that's under structural problems, right? It's an acute tear of a meniscus, an acute tear of a hamstring, an acute break of a bone, an acute tear of cartilage. Not that common. Ligament, more common. So just think of contractile dysfunction as tendinopathy. And you know how to treat those. I would put forward that as I've grown as a clinician and having gone through, extensive MDT training, if you will, I do treat tendinopathies very differently now than I used to. The main difference is I diagnose them more succinctly because I'm not being confused by mechanical joint derangements that are referring symptoms to where tendons are and misdiagnosing them as a tendinopathy. But think of contractile dysfunctions if you want to, just as tendinopathies, and then contractile dysfunction, the contractile tissue is tendon or muscle. If there's a muscle tear that's affecting its ability to contract, obviously we know how to treat those, but that's something that I would say is structural, meaning you are giving it time and you are giving it possibly anti-inflammatory inflammatory mediator therapies if you need to really rush the problem along and try to fix it sooner than it would with natural healing. But that's a lesion, and structural lesions are fixed with time and an environment for healing, and then a rehabilitation program if needed, meaning sequelae happened because the muscle was torn and the patient didn't do XYZ, or structural lesions are fixed with surgery in a rare minority of cases, unfortunately done much more than needed in this country. So those are contractile dysfunctions. Articular dysfunctions, just think of tight tissue. And tight tissue can happen. Another thesis of mine is that in orthopedics, we are blaming tight tissues left and right when there's no reason that tissue got tight. Therefore, the tissue isn't actually tight, it just feels tight, and something else is the root cause that is causing that patient to say, my biceps feels tight, my hip flexor feels tight. Muscles and other tissues do not just get tight randomly, although that seems to be a commonly accepted idea. If there was an immobilization in a cast, if there are weeks of bed rest without moving, possibly. If there was surgery and scar tissue formed very quickly, then it gets tight, right? Articular dysfunctions, just think of tight tissue. Have I diagnosed tight tissue recently? Once in a person who was immobilized in a bed for a while and had another injury, so this, prevented this young woman from moving her shoulder. Yes, I think I've seen some tight tissue, but because the prevalence is so rare, it's lower on the totem pole in terms of diagnostic thinking when you're evaluating somebody. So going back to that kind of mechanical idea, contractile dysfunction, tendinopathy in my mind, articular dysfunction, tight tissue in my mind, those are extra articular phenomena. Meaning they're outside the joint. That's why I don't really think of those as mechanical in my mind. I think of a mechanical problem as something that's interarticular or intra-articular within the joint. That's just how I view it. Postural dysfunction, that third arm, if you know it's rare, that's all you really need to know. It's not going to be something else. It's going to typically be that young person, and you can move on. You don't have to spend too much time on a person presenting with postural pain because of the rarity of that person presenting to a clinician, because they realize when they get out of that position or posture, their pain goes away. But you may encounter them from time to time. Now, structural lesions, I think, are the biggest kind of group within the other, but that other bucket is large. So for me, I like to think of mechanical joint derangements are going to be about 75% of your orthopedic disorders. Tendinopathies and structural lesions, probably a close second and third. Depending on where you work, you may see more of something versus another thing. Of course, do I think there are more broken bones, torn menisci, torn labrums, torn muscles in as a group versus tendinopathies? Maybe, but one problem with trying to figure out the answer to that question is that so many people are diagnosed with torn menisci, torn labrums, etc. When yes, they may be torn on the image, on this sophisticated picture from this, the last 50 years, but it's not an actual diagnosis because it's not related to the person's complaint. Bone fractures, muscles tearing or tendons avulsing from bones, ligaments tearing completely, those are less debatable, they're more binary. So those structural lesions are more obvious and easy to diagnose, but all those other kind of structures around joints, they are often there and not often the problem. So think of mechanical joint derangements, tendinopathies, structural lesions, and then, sometimes tight tissue and sometimes other things within the other that a lot of them I think are non-musculoskeletal system in origin, meaning like nerve problems that are caused by systemic disorders such as diabetes, or frozen shoulders, which are probably manifestations of insulin resistance or thyroid disorders or other systemic non-orthopedic disorders. They're presenting with orthopedic symptoms, if you will, but in that other group of lots of different diagnoses, you're going to have things like that are actually stemming from what I believe to be root causes that are outside the musculoskeletal system. Yes, you could argue that someone could be in a cast for a humeral fracture and then it freezes, and that's kind of more orthopedic in nature. That's true. It's more of a failure, I think, possibly about early passive movement, but it's also probably something in that patient's health milieu that created that kind of freezing of the capsule in that person versus another person. That's not a conversation for today, but what I wanted to convey is just how I think clinicians, how to treat tendinopathies, it may evolve. How to treat tight tissue, which may evolve as well. The main evolution for me, like I said, is the diagnosis process, but it's also the kind of simplifying the treatment. For tendinopathies before, I remember just like strengthening lots of things, but I don't do that now. I look for root causes or predisposing factors, and then I start remodeling, loading that tendon. Going back to that, so tendinopathies, something may be tight, and then other diagnoses. But clinicians, we know how to treat those things. If you're learning MDT, you don't know how to treat mechanical joint disorders, and you don't know how to find them. So repeated movement test is, I think, why you're going to learn MDT. You're going to learn repeated movement testing. You don't need to worry about thinking about reinventing orthopedics for yourself. You're not learning how to treat a tendinopathy. I mean, again, it evolves, but you've already learned that. Same with tight tissue. You kind of know how to treat postural syndrome, teach people how to sit or avoid that posture, make sure it's not anything else, something more sinister, etc. And all those other things like frozen shoulder or structural lesions or peripheral nerve entrapments, you've already learned how to treat those as well. And again, getting a new lens through Robin McKenzie's eyes, through the eyes of people who use repeated movement testing, I think will make those skills even sharper. But going to MDT courses, reading the MDT books, all of that stuff is to learn repeated movement testing so that you can be a better diagnostician for all those other things, because you're not going to incorrectly diagnose them when they're not. The problem in a mechanical joint derangement is it's going to make you a better diagnostician, and it's going to make you effectively treat the biggest cohort of orthopedic disorders, which is mechanical joint derangements, using on average 1 to 2 specific movements. I've delineated how sometimes, especially with shifted people or unilateral presentations in the lower extremity from lumbar joint derangements, I use 3, going from side glide to hips off center to extension. But if you read a lot of the case studies, they're usually 1 to 2. Now, are we talking about 1 to 2 directions or 1 to 2 very specific movements? We're typically talking about 1 to 2 very specific movements. that makes me think of the bigger question, which is, well, if someone got 10% better with one movement and then 90% better with the second movement, did they need the first movement? Well, probably not. But you got to the second movement because you went through movement one. But if we could roll back time and go just to the second movement, they probably would have gotten 100% better with that second movement, which would make that person's therapy just one movement versus two, if that makes sense. But learn repeated movement testing. That's what you're there for. In my mind, you're not there to learn how to reclassify all these different types of orthopedic disorders. You're gonna see a lot of tendinopathies, you're gonna see a lot of structural problems, you're gonna see a lot of these little other things, a lot meaning like a decent amount of lots of different other things, but you're gonna see mostly mechanical joint derangements if you know how to find them. And I promise you, from my personal experience, I'm always getting better at repeated movement testing. It's just because it's a living, breathing, more challenging assessment, diagnostic process. It takes longer to get proficient at it than it does doing a quick ligamentous test, right? Or just testing to see if someone's tendon is weak and painful. The biggest thing that I've improved with in the last 1 to 2 years is really kind of being more patient with holding positions, whereas I think earlier maybe I would have done, for example, 100 side glides, held it for 30 seconds, not seen a change, and moved on. Now I'll do 100 side glides, hold it for 30 seconds, hold it for 60 seconds, hold it for 60 seconds. If all the data I've collected so far point to that being a likely treatment strategy, I will explore it further and hold sustained positions longer. And if I only see maybe a smidgen of a change in the clinic, before I would have probably dismissed it as not sufficient enough to warrant doing more of that specific movement at home. Now, most of the time, if everything else is pointing to that, and that example, that movement gives me 10% change of something in the clinic, like nerve tension, it's like a little bit better. The patient can notice it's a little bit better. I can notice it's a little bit better. Before I probably would have skipped it, but now I don't. So I'm excited to see what I'll get better at in the near future and the far future, because the more hundreds of patients and thousands of patients you do this with, you will see those types of patterns and prevalences. You'll see things that you didn't see before and get better at using it. So I don't know if this framework kind of helps people, but I really want clinicians to not be, I guess in a word, intimidated by having to learn this whole other system and classification system, when what you can really think of is, I'm learning a really important test. And it's a test that doesn't take, 10 seconds to perform or 1 minute to perform. It takes, over the course of days to perform, but in the clinic it takes 5, 10, 15, 20 minutes to perform correctly. So just learn or think about, I'm learning repeated movement testing to find mechanical joint derangements, and make sure that all my other diagnoses are more likely to be correct because they're not derangements, which is the largest cohort of orthopedic disorders. If this helps, or if this doesn't and you totally disagree, I'm curious to hear your thoughts, so just let me know.